at such short notice. Thanks.
Talk about the role of robotic surgery in lung cancer. As we're all aware, lung cancer is a huge problem, the biggest killer for cancer-related deaths in the U.S. See if I can make this work. There we go. So in 2021, there were 235 new cases of lung cancer diagnosed in the U.S. Of that, 131,000 deaths in the U.S. So again, the largest number of cancer-related deaths in the U.S. from year to year. Of those, the vast majority are non-small cell lung cancer. In the treatment algorithm, the treatment is stage specific. So based on stage 1, 2, 3, or 4, most of the patients I see are the stage 1 and 2 categories. For stage 4 patients, there's really no role for surgical intervention. But the options for treatment include surgery, chemotherapy, radiation, or radiofrequency ablation. As far as the surgical options, the extent of resection has been the same for a number of years. The options include a wedge resection, segmentectomy, lobectomy, or pneumonectomy. And it's all, a number of factors go into contributing to what we actually decide to do for a given patient. Those patients who have poor lung function, FEV1s in the 30 to 40% range, end up with wedge resections. For patients who have excellent pulmonary function, the lobectomy has been the standard of care for some time. As far as the method of resection, surgery has been an option for 40 to 50 years now for lung cancer. In the past, surgeons have used the open procedure most of the time. In the last 20 years, that has changed dramatically. The thoracoscopic approach, or the minimally invasive approach, was developed approximately 15 years ago, and it's evolved to a certain extent with the role of laparoscopic surgery. But there's a lot of limitations, and part of that was technology related. So in the past 10 years, the robotic-assisted approach has evolved dramatically, and it has to do with the technology that's developed side by side with the Da Vinci program. Da Vinci is the manufacturer of the robot that has been used for the last 15 years, and it's evolved quite a bit. This picture shows the third generation system, which had a lot of applicability, certainly been used in urology, general surgery, and gynecology. With the fourth generation, still up in the last 4 to 5 years, the roles have been expanded considerably, primarily with the use of staplers and something called ICG, which is a chemical we use to help assist us in identifying what's been perfused and what hasn't been. This slide depicts the changes in how approaches are being used by surgeons across the U.S. I think the older thoracic surgeons have been slow to adopt new technology, which is common throughout our society. But up until 2018, the robotic role was improving significantly, and since that time, it's continuing to evolve. And so the robotic resection will soon become the standard of care for elective thoracic resections. There's a lot of benefits to the robotic approach, which are listed here. The length of stay has been dramatically decreased. In the past, the average length of stays after a thoracotomy for a lung resection were in the 5 to 8 day range. Now the standard length of stays decreased to 2 to 3 days. Complication rates as far as blood utilization, cardiac rhythm problems have all decreased in response to using the robotic approach. Decreased morbidity, mortality. The nodal sampling has been something that the surgeons have been critical of as far as the thoracoscopic approach versus the open approach, but with the robotic approach, we get equivalent node sampling to an open approach. This is just a slide that outlines some of the benefits of the robotic approach versus the open approach as far as documenting the fact that fewer complications, a decreased length of stay, and postoperative complications. And this is a slide that's comparing the VATS lobectomies to robotic-assisted. And again, robotic comes out ahead in the vast majority of categories. Nodal upstaging is a process by which surgeons identify the number of nodes that we excise during the course of a resection. In the past, certainly our imaging studies, whether it be a PET or CT scan, were somewhat limited in what we could actually sort out as far as nodes. So surgeons would get to the operating room, do a thoracotomy or thoracoscopic resection, and find out that you have more nodes than we anticipated based on the imaging studies. So that when people would compare the thoracoscopic approach versus the open approach, they couldn't get as many nodes out with the thoracoscopic approach. But with the robotic approach, the node sampling has been equivalent to the open approach. So the criticism that went along with the thoracoscopic approach has disappeared when you use the robotic approach. We've used all kinds of incisions over the years for lung resections. On the your far left, there's the thoracotomy incision, which can be a pretty big incision from time based on the surgeons. The robotic the approach is on the far left, on your far right, which again we have 4 small incisions. And then we have basically the one at the very bottom is what we use to take the lung tissue out with. I did a case just 2 days ago, and the incision was about 2 inches long to get out the left lower lobe. So you can get out the lobe through a fairly small incision because the lobe collapses once the air has been evacuated. And these are some of the horror stories we all have seen after open approaches and the scarring that results from a big whack. This is our typical setup in the operating room for a robotic approach. We're using 4 or 5 ports, is what you see, those metal things with the white caps on them. And that's a typical approach. Just want to talk about a couple cases that I've had over the course of the last 18 months since I've been doing the robotic approach. The first one's a 78-year-old gentleman who sells metal buildings, had a long history of tobacco use, had a large and left lower lobe mass, documented by PET, was biopsy-proven non-small cell. Had a robotic left lower lobectomy, was in hospital 2 days, no complications, path was a T1N0 non-small cell, and at 3 weeks in back of the office, he wanted to go back to work. So. The second case was an interesting patient that kind of demonstrates some of the huge benefits of the robotic approach. She was a lady who I did a left upper lobectomy on in 2005 for an early non-small cell lung cancer. She did well after that, but developed a recurrent lesion in the right upper lobe last fall. The biopsy came back as a bronchogenic adeno, which was, again, a metachronous primary, a second primary, almost 15 years removed from her first primary, although she had a previous left upper lobectomy done already. So the question is what to do with this lady who's had a previous upper lobectomy and a biopsy-proven new primary. This is the CAT scan that demonstrated her lesion in the right upper lobe. The right upper lobe, as you all know, has 3 segments. There's an apical segment, an anterior segment, and a posterior segment. And certainly the literature is clear that sublobar resections work in certain situations with equivalent recurrent rates to lobectomies. So the question was, would this lady qualify for a segmentectomy versus a lobectomy? She was seen by some physicians who thought a lobectomy would be somewhat difficult given her previous upper lobectomy. But given the location, we were able to do an apical segmentectomy. So again, we took out 1/3 of her right upper lobe, leaving the other 2 segments, plus the remainder of her right lung. And she was out of the hospital in 3 days and did fine. This is just a brief slide demonstrating that on the right side there's 3 segments, the apical, anterior, and posterior. We took out the apical, which is number 1 on that segment. The robot allows us to do that because we had different tools we didn't have in the past. And this slide identifies some of that. You see this green chemical in the bottom of the slide. That's a chemical called ICG, which the anesthesiologist gives during the course of the operation. We actually lights up to perfuse tissue. And so what we do during the course of the operation is to divide the artery going to the segment involved so that segment has no blood supply. And so that's why it remains black or dark. And once they give the chemical, we'll see the segments that light up with the green, which demonstrate what's perfused. And what we want to do is divide the area that line was perfused and non-perfused. In the past, with a thoracoscopy or open, we didn't have a good way to actually identify what was being perfused and what wasn't, so segmentectomies were difficult. But now that we have a chemical that identifies that line, that plane, it makes it much easier to resect the area that's not perfused and leave what's left. So in summary, robotic resections result in decreased length of stay, decreased complication rates, decreased mortality, equivalent nodal sampling to open procedures, decreased morbidity, and the sublobar resections become much easier to deal with. So in the past, I've done about 50 or 60 robotic lobectomies. Patients have done amazingly well. Complications rates have been very low. Mercy Hospitals just kind of allowed us, got their new robot in the last month. So all that stuff's been done at SRMC for the last 18 months, but we may expand to Mercy sometime in the next month or two. So.
Thank you.